Thank you very much, Chairman. This is really my pleasure and honor to give a presentation on large-scale HCV and HBV screening in Taiwan. And as shown on this slide, as you can see that there's a quite consistency in the global liver cancer incidence and HBV and HCV prevalence. In this high liver cancer incidence area, the prevalence of HBV and or HCV are quite high. And this is especially in this Asian Pacific region. And on this slide, we compare this age standardized incidence and mortality rates of liver cancer in 21 Asian Pacific Economic Cooperation economies. As you can see here, for this liver cancer incidence and mortality, among these 21 APEC economy, the highest is in Thailand, followed by Taiwan, Vietnam, China, South Korea, Philippines, Singapore, Japan, Hong Kong, and Brunei. And this slide shows that since 1997 to 2017, within these 20 years, we try to look at this secular trend of age standardized mortality from liver cancer from in 6 APEC countries. And as you can see on the left-hand panel, that's for the males. In Taiwan, South Korea, and Japan, and you can see there's a very striking decline in age standardized mortality from liver cancer. And we compare with the United States, still in Taiwan, South Korea, and Japan, we still have higher age standardized mortality from liver cancer compared to the United States. And this is also true on the right-hand side panel for the females. And in Taiwan, we started our national hepatitis B immunization program in 1984. For the first 2 years, only newborns of surface antigen carrier mothers get vaccinated. And after July 1986, all newborns receive immunization, and we have the first dose within the 24 hours after birth. And in 2015, World Health Organization proposed a programmatic target for viral hepatitis elimination. I believe every one of you here know it very well. With regard to the 3-dose hepatitis B vaccination for infants, the target is 90% in 2030, and in Taiwan, we achieved this target in 1989. And with regard to there's a prevention of mother-to-child transmission of HBV. This means that the post-dose vaccination, the target is 90% in 2030, and Taiwan also reached this target in 1989. For the blood safety, injection safety, and harm reduction, Taiwan also achieved the goal. However, we are trying our best to reach this goal for the diagnosis and treatment of HBV and HCV. Not by 2030, we try to reach the HCV elimination by 2025. And this is the key milestone for hepatitis B and hepatitis C elimination in Taiwan. It is a quite busy slide, but I would like to call your attention on this circled statement. That's, in Taiwan, we started antiviral therapy for HBV and HCV reimbursed by our national health insurance in 2003, but with a very stringent eligibility criteria for antiviral therapy of HBV and HCV. And our Health Promotion Administration launched a once-in-a-lifetime HBV HCV screening program for limited birth cohort. It means that for the birth cohort with high risk, most of them were aged greater than 55. And in 2017, we started this DAA treatment, and it is totally free. And it was reimbursed by our national health insurance for adult CHC. Patients with fibrosis staged greater than F3, but we expand this kind of treatment criteria, and by now, that's all CHC patients got this free treatment. And in 2020, as you can see here, that's an HP Health Promotion Administration expanded the HBV and HCV screening for all adults aged 45 to 79 years old. And for the indigenous people, because they have high prevalence of viral hepatitis, their age will expand from 45 to 40 and above. And we try our best to reinforce this screening project in 2023. And in our schedule, as you can see, this is an entire population in Taiwan. And for those who are under 45 years old, we raised this liver health awareness. For adults above 45, we have stratified this our townships by this low risk area, middle risk area, and high risk area. And for the entire general population screening, we pay more attention to the extrahepatic comorbidity patient, this including the diabetic patient, chronic kidney disease patient, and pre-end stage renal disease patient, as well as cardiovascular disease patient and patient with rheumatoid arthritis. And on the right-hand side, as you can see, in addition to the general population screening, we have a special population screening, this including the patients with dialysis, HIV infection, and also the prisoner and methadone maintenance therapy, as well as patients with sexually transmitted diseases. And there are also some patients who visit this medical institution for routine screening, for health checkup, or that's because they have got some high-risk experience, such as accidental needle stick or invasive testing or endoscopy, or patients with the abnormal functions. And they are also tested for HBV and HCV. And all these informations are digitized and enrolled in this our national health insurance system. So with this data, and as you can see here, from 2011 to 2024, for HBV, HCV screening in adult health examination, and in total, we screened more than 4.6 million people from the general population. And on the right-hand side, and as you can see that if we include also those who have been tested for HBV and HCV in the hospital or clinic for medical reason, and that's around 1.9 million. In total, 6.5 million people that have been tested. This is around 60% of our target population. And as you can see here, that's the HBV surface antigen and anti-HCV seropositive rate. And the positive rate decreased from 2011 to 2024, and also for anti-HCV prevalence rate. And this is also shown on these figures. And after we started this screening program in 2011, and the HCV prevalence and also the HBsAg prevalence are high. But when we screen the more and more people, and then you can see the prevalence is getting lower and lower. The reason for that is that before 2020, we focused our screening effort on the area with high incidence, so-called the high-risk area. So we have high prevalence rate. And this is a busy slide as well. But you can see that I just want to show you that if you look at this on the age from 45 to 84, and for anti-HCV seroprevalence, and the age at 45 is around 2% for anti-HCV, but it increased with the age. And at age of 84, you can see the prevalence is around 6%. And for the hepatitis B surface antigen seroprevalence, it's just contrary, and it decreasing from 13% at age of 50 to 6% at age of 84. So this is the overall picture of the prevalence from age 45 to 84 in Taiwan. And This slide just show you this, the number of participants in HBV HCV screening from 2020 to 2024. At the very beginning of 2020, and there are more people have been screened. And then since we have a very good coverage, so the number of participants are getting less and less. But more importantly, I would like to share with you that in Taiwan, most of this screening effort was done in the clinics of the community. Public health centers took around 13%, and clinics, private clinics, took around 60%. For the hospitals, basically, they contribute around 30% only. And this is anti-HCV prevalence by city and county. Some of the counties in Taiwan, such as Yunlin County, Jiayi County, and Jiayi City, they have very high prevalence. But in this metropolitan city, you can see the prevalence rate is lower than 2.5%. And overall prevalence rate of anti-HCV in Taiwan is 2.6%. And for this HCV RNA testing rate is around 80%. And this is by the end of 2024, because still some anti-HCV positive persons are waiting for HCV RNA testing. And the DAA treatment rate is in almost all these townships are higher than 90%. And I would like to go through some of the special group with you for this HCV care cascade. And for this end-stage renal diseases patient, because they got this hemodialysis, and they visited this hemodialytic center frequently, and in total we have around 100,000 ESRD patients, and 99.9% got the screening, and 11% of them are anti-HCV positive, and 90% they get this HCV RNA tested, and HCV RNA positive rate is 63%, and this DAA treatment percentage is 97%. And this is this HCV care cascade for HIV patient. And in Taiwan, all the HIV patients get this free treatment from our CDC. So we have a very good record of HIV patient. It's around 37,000 patients of them. And 99% got the screening, and the anti-HCV positive rate is quite high. It's 29%. And the HCV RNA testing is 80%, and the HCV RNA positive rate is 77%. And this treatment rate is 95%. And for the other special group, I won't go through the detail, but you can see here, this for the patients in prison. We also have very high screen rate. This is around 30,000 prisoners, and 68% got this screening. And Professor Yu Minlong, he's going to give a presentation in the afternoon. So he will share with you how we engaged in this HCV care cascade for patients in the prison. And for the opioid substitution treatment, we have around 10,000 people, and around 90% screened, and they have very high anti-HCV positive rate, and also HCV RNA positive rate is high. But once we identify them, they got a very good DAA treatment. And this is for DM patient. And because HCV was associated with DM, so it's around 2 to 3-fold. So we consider this patient in our DM integrated care program has to be tested for HBV and HCV, and these are the around 1 million DM patients are well focused and well prioritized to be tested for HBV and HCV, and the data here is around 80% got screening and 97% got the DAA treatment. We also, we also focus on this early CKD patient, because we have chronic care. There's an integrated care program for chronic diseases of DM and CKD. And as you can see, around 600 CKD patients well registered, and they also high percentage of screening, around 84% were screened, and 97% got the DAA treatment. And this is for end-stage renal diseases patient. It's around 100,000 patients, and also the screen rate is high, 87%, and DAA treatment percent is 97%. And this is for the general population, and I would like to pay more attention to this and the data. And our targeted population is around 10 million people in Taiwan. And I just mentioned about this two channels to identify the HBV, HCV patient. One is through this health examination checkup. Another one is from this hospital and clinics for this when they have a clinic visit. So in total, there's around 6.9 million people have been screened, and 95% of this HCV RNA patient has been treated in Taiwan. And this is the use of DAA treatment by month. We have a very good track record to check these patients after the treatment. And by the end of 2024, around 74,000 patients has been treated with DAA. And with regard to the efficacy of DAA treatment, as you can see on the left-hand side panel, it's very high. It's in real-world effectiveness of DAA treatment for SVR12, as 12 months of the treatment is greater than 98% in recent years. And there are some reasons for missing this SVR12, as most of the patients, after they complete the treatment, they won't show up to be tested for this viral load. That's the reason why we have some missing data here. And from this our effort, these are the current status of HCV elimination in Taiwan in 2025. We have around 93.9% diagnostic rate of chronic HCV patient, and around 92.8% of treatment patient with chronic HCV infection, and for the medical injection, blood transfusion safety, as well as this providing injection set to each PV patient. We all reach this the WHO target in 2030. Through this kind of effort, did we really achieve this the decline of the liver cancer incidence rate? The answer is yes, but not. We still have to put more effort on it to make it lower. And as you can see on the left-hand side is this circular trend of liver cancer incidence rate by age. And for this age greater than 70, the incidence of liver cancer declined after year 2007. But for those in the age group of 50 to 69 and 30 to 49, and you can see the incidence rate declined from 2003. So indeed, we found that our HCV and HCV control decreased the liver cancer incidence. And in Taiwan Cancer Registry, we also have this data about the HBV and HCV data. And as you can see on the right-hand side, yes, indeed, there's a decline in liver cancer incidence for those liver cancer caused by HBV, HCV, or both infection. But if you look at this liver cancer incidence for non-B, non-C, not hepatitis B or hepatitis C patient, and up to this 2013, there's a level off. So we have to pay attention to non-viral hepatitis related HCC in Taiwan. So in the future, we have to try our best to maintain this very high coverage of HBV, HCV screening, and to maintain a high coverage rate of antiviral therapy, and especially for the micro-elimination program, our special group, the PV or HIV infection or the prisoners, we have to try our effort to do that. And also, we are trying to look at this, the trend of liver liver diseases, mortality, and morbidity after 2025. And MAFO is very important. So with that, I would like to thank you very much for your attention. Thank you.